Hi, everyone, and welcome to Anaesthesia Coffee Break. Now, we've got a really exciting episode. First of all, Stan is going to give his performance tip for this week, and we're going to go through all the essentials of ultrasound for this exam. Now, we'll get straight into it. Hi, everyone. My name is Lahiru.
And I'm Stan.
And let's get straight into it. So, Stan, now, we all want to be as high performance as you. What is your performance tip for this week?
Well, before we get into that, it is a new episode, and my performance tip. So I've got two performance tips for today. But my first performance tip is always make sure that you look like you've got a change of clothes, and it looks like a brand new day. So for all those who saw the previous episode, note that I've had a change of clothes, and Lahiru is still wearing the same outfit.
Oh dear.
From the last episode.
I want people to know that we recorded both episodes at the same time. So this is not a shirt a week later unwashed. Okay, it's not like that.
Yeah, well, you know, that's the last word against.
You got me.
It's what could be the truth, which is we're a week. Why the episode's being released each week? Because we just tape it. Oh, here we go. All right, very nice.
Is that okay?
Yeah, no, it's very nice, very nice. So Lars, for all the people on podcast world, Lars just put on a jacket, and just like myself, where I've just put on a new jumper, it's completely transformed himself. And I think these small little things can make a difference. And look, I want to lead that on to the idea of advocacy. So what I just did just then was I advocated for La to make a change.
That was a terrible segue, but I'll pay it because it's good. Your heart's in the right place.
You got to give me credit. Hey, I spent some time thinking about how to segues, or how to make these transitions seamless as you. So,
almost as good as CNN.
Yeah. Almost. Anyway, the idea that I want to talk about today, and it's really for those trainees that have passed or that are going to pass, as well as consultants out there and anyone listening who has someone below them. And it's the idea of advocacy. It's the idea of acting on their behalf and acting on their best interests. So an example that I'll give is that earlier this week, I started making calls around to the SOTs of various departments and speaking to those SOTs about trainees within our program, and sort of talking about ways in which we can help them through this upcoming Viva. And it was really, really positive and amazing to actually hear about what resources are actually out there for all these trainees. And when I put down the phone, I was like really comforted by how much that those departments were going to be doing for their trainees. But then after that, I got thinking, why wasn't this access prior? And this is where advocacy comes in. And I think it's something that we've also experienced as well, where we always ask for trainees to come in with their questions or come in for if they need any assistance or help. Very rare do we get those emails. And I think that there is that hesitation from the trainee themselves to actually reach out and get help. But when someone else is in a position like ourselves or a consultant or a trainee that's recently passed, they can act on another trainee. They can see, look, this trainee needs help. This trainee needs assistance. I'm going to advocate for them. I'm going to talk to someone about and get them the resources and support that they need to be successful and to bring happiness to their lives.
Yeah, I think that's really great because, if I think about every single context, I've always, like, maybe the fact that I'm a consultant now, I feel like I've got far more, confidence in asking for things and being assertive, but that wasn't always the case. Like when you're a junior, you just feel far less able. And even below that, like when you're a student or maybe you're a person who's just come into the country, you're not really sure of the system, you might be quite timid, maybe culturally wise, you don't feel like you can assert yourself. And, what is our role in life but if you're in a position of power, to be able to stand up for someone else, whatever it is, whether it's on the street and someone's getting bullied or someone's going through a hard time and you say, hey, are you okay? Can I help you? this is advocacy, right? And you know, if you've got that ability and you've got that confidence and strength, I think it's just great. Like I was an absolute nerd in high school. I'm gonna it probably doesn't come as as any surprise to anyone else.
Good looking chap like you, nerd. No.
Oh man, there's only so much chess you can play and not be a ridiculous nerd. But I was so lucky. I had these friends who were just like, a lot of them were, you know, just really, some of them were really big guys. I remember I was in band, and there's one kid who's just an absolute, you know, and he was just a bully. There's no two ways about it. And one day we're just playing, and he just comes up and punches me. And luckily for me, I mean, I had no chance against this guy. He was a rugby player, you know, first for rugby, first for rowing. And the guy next to him was older than him and bigger than him, and just punched him back. And he never messed with me, because that guy, who was not even a close friend, he was just a nice guy. We got along. He stood up for me, and that moment, it meant that that would never happen again, because I just had no ability to really assert myself to someone, you know, so much bigger and more aggressive.
That's the amazing part about this story, is that you didn't ask for him to step in for you. As in, he went in off his own bat to advocate for you and to show that you had support.
Yeah, absolutely.
And I think that's the key message out there. And I think there are so many of our peers, not just consultants, but trainees as well, who want to advocate for other trainees.
Yes.
And don't you think it'd be amazing if we got this network of consultants and trainees who are interested in supporting our primary candidates? You know, we could some way make a really good positive change through this whole process. What are your thoughts?
I think that's a great idea. I think, you know what, COVID's been terrible, but what it's done is it's linked people who are further, like, it's probably socially distanced people who are normally together, but the people who are isolated, the people in different cities and different states, it's actually brought those people together, because we've now got very comfortable with using Zoom. We've learned how to podcast. We've learned how to put things on YouTube. We've learned how to, you know, create systems to, you know, bring people together. If there's one thing that this horrible time has created, is that ability to link people who are potentially more isolated and link those who are very happy to help and want to help and just don't have a method to, you know, mobilize their resources to help others. I think maybe this is the start of something pretty big.
Well, distance is no longer an issue, and you know, the connection that we can make through Zoom, we can connect with people, not just through Melbourne, but through Australia, and not just Australia, but New Zealand as well. In fact, the whole world.
Actually, I had a really interesting thing happen just this week. I'm running that Part 2 Viva course tomorrow, and someone from Kenya is coming to the course. And yeah, so she actually attended last year. She's coming again. I thought, you know, she was actually very good. And I thought, oh, you know, what's the best place of, you know, knowledge and this shortening of distance? Why don't we help the, you know, third world countries with Zoom education if they need it, you know, like setting up things. So that's going to be the project after this weekend.
Amazing, big lofty goals.
There's so many people who are happy to help, so I think it'll be easy.
and by the way, where's my beeper? I'm still waiting for my beeper.
It's at your door right now. Amazon Prime membership. Okay, we should get on to it.
Anyway, look, I think this is it's such a great idea, and I think we're gonna have a chat about this probably more offline, and just think of ways that we can provide an avenue where we can advocate for trainees, and we can bring in that support and link in all those consultants or trainees who are interested to supporting others. And when we're not going to be limited by distance. And I think it really helps, because one of my, I get very emotionally invested in all the trainees sitting their exams. And one of the things that I feel guilty about is that I just don't have the time to spend with each one the amount that I think they deserve. So, you know, I think a solution around that is that there are really so many people out there who want to help, and let's tap into that.
No, I think that's great.
An amazing resource, hey?
I think that's really great. I'm excited with what this brings. So if anyone has any ideas, if they need help email us, lahiruandstan@gmail.com. So please email us. Maybe you want to help out. Maybe you want to offer some advocacy, some kind of training, whatever it is. If you want to be a part of this, please email us with any questions, any suggestions, short answer questions, Vivers, mentoring, whatever it is. And I think we've got a pretty good platform now that we can make this happen. Let's do it. Okay, let's get on to ultrasounds. That's what you came here for. Hardcore first part knowledge. So Stan, ultrasound. I know you use ultrasounds a lot because you do so much regional anesthesia. I also love ultrasound. I love regional anesthesia. How does this amazing device work?
So the way the ultrasound works is that it produces sound waves, and it produces sound waves with frequency above human hearing. So that's often quoted at a bit more than 20 kilohertz. So the range of ultrasound that are often produced often range from 2 to 15 megahertz. So big difference, okay? Now, the basic features of an ultrasound. So this is really just a summary of the way that I think about this and the way that I sort of can sort of transmit that knowledge to you. So one is it's sound waves generated from a piezoelectric crystal, which deforms when voltage is applied to it. Secondly, it's transmitted through the body tissues and reflected back from different tissue interfaces, which is then picked up by the transducer and then converted into an image. So it's really interesting so this is just really at its basic core when you think about one piezoelectric crystal. But the ultrasound that we use in our everyday clinical practice has multiple piezoelectric crystals, each sort of generating multiple different waves, and each at the same time taking turns into picking up the reflected sound waves and becoming the transducer. So the other basic idea about an ultrasound is that it's related by the formula, and this is very important to know. It's lambda, which is your wavelength, multiplied by the frequency equals your velocity. And knowing that formula allows the ultrasound probe to calculate the time it takes for those waves to go there and back. And that gives you the velocity, and working that out, you can actually work out the depth, okay? Because it knows the frequency and it knows the wavelength, and all it does is it's got the time, and from there, it can actually work out the depth. So that's how the image is ultimately produced with an ultrasound. Now, the waves that are produced with an ultrasound can either be reflected, and they can be reflected in either a specular, which means like a mirror image, or a scattered manner. The other thing is that it can be refracted or it can be absorbed. So the amount of reflection depends on the different acoustic impedances between the two mediums, as well as the angle of reflection. So for example, when you're using your ultrasound probe, the best image that you'll get is when it's 90 degrees to whatever you're looking at, okay? The more angle you have with the probe, the less quality your image is. So the classic example is your needle. If your needle is at a shallow angle, you will tend to get a really good image. But if your needle is a very steep angle, then what you'll find is that the image of the needle actually goes. And so the trick to that is to actually change the way you orientate your probe from a horizontal lie to actually a lie that so that the beam is 90 degrees to the needle.
Oh, that's a great tip. Let's say sometimes you just don't want to have if your needle enters next to where your probe is, it's going to be a shallow angle.
That's right.
So, but if you come out too far, that means that it's often hard if it's difficult tissues, difficult positioning to get that needle into view at exactly the right plane at the structure. So what you're saying is, there's your probe, there's your needle. If you were to just turn it this way slightly.
Correct. And so that your needle is at 90 degrees. And so your probe is at 90 degrees to the entering needle. So that's a trick that will actually allow you to actually visualize your needle a lot better.
I've got to say, I thought I knew all the tricks. I've never heard of that trick, and I'm gonna have to call it Stan's trick from now on. Is that your trick? No. This is
I'm sure you can find all these tricks on YouTube. Okay, so
as far as I'm concerned, Stan, congratulations on authoring.
I'm just regurgitating all this. All right. So now the other thing I talked about was that waves can also be refracted. So refraction occurs when you get that change in the direction of the sound. And so it occurs between tissues of differing speeds when the angle of incidence of the sound wave is not 90 degrees. So if it's 90 degrees, it hits straight back up. But if it's not 90, or sorry, it hits straight down. But if it's not 90 degrees, you get that little bit of refraction. So now the thing to note is that sound in water is about 1,540 meters per second. The thing about tissues, about body tissues, is that it's all within sort of 10% of one another. So with all the soft tissues, including fat, you've got you know, a range, and you'll see different numbers between 1,450 to 1,650. Okay, so, but it's within 10% of what sound is transmitted in water. So what that means is because there's a difference of less than 10%, you're not going to get that much refraction in body tissues. But it does also explain why sometimes you get a little bit of artifacts. So, you know, those things where you go, what is this? It's most often an artifact, and it's most often an artifact because of the differing velocities in the different mediums. Now, the only body tissue, which is bone is completely different. So bone has a velocity which is often quoted between 3,000 to 4,000 meters per second. But once, and we can sort of describe what happens when you try to ultrasound bone, you get dropout. Mm-hmm. So I think we'll sort of discuss this sort of further on. And then the last thing is absorption. So the absorption of a sound wave is dependent on the frequency that the sound waves are emitted from the piezoelectric crystal. So high frequency equals high absorption, low frequency equals low absorption. And we'll talk about what the implications are and how we can sort of change.
Sounds good. So if I'm going to go through, we've got some images, but it's not important for you to see the images because you can probably just, you know, Google any kind of ultrasound brachial plexus and see these kind of images. Now, underneath the skin, you get this first bright line. It's usually just above the vessels, above the big vacuous circles. What is that bright line?
So that is fascia, and it's hyperechoic. So what the bright line means is that there is a lot of waves being reflected back at that interface. And what happens is that because there's two different acoustic impedances, you get that reflection that occurs, and it's picked up by the transducer. And because there's a lot of, and when I say a lot, you'll see afterwards, I'll do the calculations for you. It's relatively a lot, but it comes up as a white line. So we call it hyperechoic.
When I think of a fascial plane, it's got lots of layers, lots of slightly different impedances, therefore lots of reflections and refraction occurring.
Yeah, or we can say that it's between a layer between subcutaneous tissue, mm-hmm. and then after that you've got the fascial layer, and then after that you've got muscle or fat. Okay, mm-hmm. So it's just between that fascial layer, which has its own acoustic impedance, mm-hmm. versus the muscle below. Mm-hmm. And also you're also thinking about the layer between subcutaneous fat and also that fascial layer as well.
Okay, so if you asked what is acoustic impedance, what's an easy definition for that?
Yeah, so look, acoustic impedance, which is often defined by the letter Z, and it's measured in rails. It's described
rails as in R-A-L-E-S?
R-A-Y-L. Look, I may not be pronouncing it right, so I do apologize. I think it's from Rayleigh, what they call Rayleigh scattering. Rayleigh, R-A-Y-L.
Oh, R-A-Y-L, rails.
R-A-Y-L, sorry, R-A-Y-L, yeah. Rails.
Or Raleigh. It's one of the two units of specific acoustic impedance, or equivalently characteristic acoustic impedance. Okay, good.
So it's measured in RAYLs. I think it's rails, but it comes from the Rayleigh scattering, from the name Rayleigh scattering, and it describes the difficulty or resistance of the sound wave as it encounters. The resistance that the sound wave encounters as it's being transmitted through a medium, and the formula for that is it is equal to the density multiplied by the acoustic velocity. In other words, if you have a medium with high propagation speed, you're going to have high acoustic impedance. And if you're going to have a medium with high density, you're also going to have high acoustic impedance. So it's a little bit counterintuitive, because often you think if you've got something with high resistance, mm-hmm. you're going to have low velocity. But this describes the acoustic impedance. So it's just about the property of the tissue. So because sound waves are transmitted at different speeds in different mediums, what it's saying is that with mediums with high transmission of sound waves and high density, those are going to have high acoustic impedance. Now, an example is, okay, let's say you've got fat and muscle. So fat and muscle have an acoustic impedance difference that is actually quite small. And the reflection coefficient, which is a formula that you'll see sometimes, is the acoustic impedance in let's say muscle minus the acoustic impedance in fat squared divided by the acoustic impedance in muscle plus the acoustic impedance in fat. And that gives you a reflection coefficient. And that reflection coefficient gives you an idea of the percentage of waves that are being reflected. So the reflection coefficient between fat and muscle is actually anywhere between 1 to 2%. It means that only 1 to 2% of those waves are being reflected. But if you compare that to bone and muscle, if you actually type in the reflection coefficients of bone versus muscle and plug it into that formula, you actually get a number closer to 50%. In other words, 50% of those waves are being reflected, which is why when you do ultrasounds on bone, you get a massive amount of reflection. And that's why it comes as a very, very white, as a big white line. Okay.
Oh.
Now, what's interesting is that, you get those, you use those ultrasound needles and they come up really bright on the screen. And so you're going, that's really bright. And so what happens is that there's a lot of sound waves being transmitted from that ultrasound needle.
Yes.
And what you see later on is that you get that what's called acoustic shadowing. So acoustic shadowing is because a lot of those waves are being reflected up or reflected, you've actually got less transmission of those sound waves. And that's why below bone, you see it all black. All right.
Yeah.
So, but then with a needle, you actually don't see that acoustic shadowing. And the reason for that is because a needle is, its diameter is very narrow. Like it doesn't cross the whole screen. So you remember that the ultrasound has got multiple piezoelectric crystals, and what it does, it sends multiple waves down. So only a segment of those waves are encountering the needle. So that's why you don't get acoustic shadowing with ultrasonic needles.
Interesting. Literally because they're so thin that.
So thin.
Yeah, interesting.
Right. Yeah. Whereas, if you got something that's quite thick, so if you use like a large bore needle and your ultrasound probe, and you're using you sometimes use there's a really small ultrasound probe that you can use, but when you use a large bore needle, you'll actually see shadowing. So you'll actually see the dropout that occurs.
Yeah, right. That's interesting. I did wonder why that would happen. And, it's just really, really useful that it doesn't, obviously, otherwise it'd be very difficult to keep locating your structures.
Yeah.
Should we move on to the next question? So now, again, we've got a picture here of the brachial plexus. When you're scanning across the neck, there's so many structures there. What is this large circle black structure, and why is it black? So
remember I talked about acoustic shadowing, and that causes the anechoic or hypoechoic nature after the bone. So that was because of acoustic shadowing. So the other reason why there's a black structure is because of Rayleigh scattering. Okay. And what that means is that there's red blood cells in those vessels. And when you've got little small structures, they cause reflection in all sorts of different directions. So in other words, the echoes are not returning back to the transducer, and they're not being received by the transducer, and that's what causes the black circle. It's because of the red blood cells and the idea of Rayleigh scattering.
Excellent. So what is the difference then between scattered and specular reflection?
So just to summarize, specular, which means mirror, it's from large and smooth objects producing angle-dependent intense reflection. So the example is bone. And scattered reflection is from small irregular objects such as blood cells, which produce all sorts of different types of reflection, so much so that it doesn't head back to the probe. All right.
Okay, excellent. Now we've got this again, this image where it's zoomed into the surface of probably
the
quiver or
humerus.
bone, really.
Yeah.
What is this white line and why is it white?
Yeah. So just to summarize again, remember that bone has such high acoustic impedance that the interface between muscle and bone produces a large amount of reflection, which is then presented as a bright hyperechoic rim. And because there's so much waves being reflected and less of it being, which can go past the bone, that's what's called acoustic shadowing. So the two things that causes the black structures in your ultrasound are from acoustic shadowing and are from scattered ultrasound waves or Rayleigh scattering.
Okay. And why is it dark after that?
Well, that's because of acoustic shadowing.
Yeah.
So in other words, there's just no ultrasound waves that are being able to actually go past that acoustic impedance because a lot of those sound waves are being reflected back.
And how does frequency affect the quality of your picture?
Yeah. So I think you do this sometimes when you've got really deep structures. So I'll often change the frequency, and the way that you can change the quality of the picture with depth is to lower your frequency. So by lowering your frequency, you increase the depth of that the ultrasound waves are able to penetrate. Because remember that absorption is based on the frequency of the waves. So if you've got high frequency waves, most of it is going to be absorbed right from the start, and so less of it, and so you're going to get less penetration. But the flip side to that is that the lower the frequency you use, the less your resolution is going to be. So that's the trick with deep structures, is that yes, you can use lower frequencies, but you'll find that the resolution is never as good as what you can find with something with structures that are a lot closer. So look, the challenges are in as the population becomes larger and larger with obese patients. Using ultrasound in those patients are actually quite tricky, especially with doing blocks. And I'll see that, and I'll see a wide variety of anatomy with interscaling blocks, which I do primarily, or brachial plexus blocks. So there are some patients where when you pop the ultrasound on, you actually see the brachial plexus, honestly, like less than a centimeter from the depth of the skin. And then I've had other patients where I've done the ultrasound where it is about 2 to 3, it's almost about 3 centimeters down, which is actually very far down. Because consider this, I only use a 50 millimeter needle or 5 centimeter needle. And to get to that structure, which is about 3 centimeters deep, I have to put my whole needle in. And when you're looking at those structures, they're never as good as a structure that's closer to the surface.
Yeah, it's like the degree of difficulty suddenly increased so much more.
So much more, that's right.
Yeah, I remember having this patient who was, I think he would have been over 200 kilos and trying to do a sciatic nerve block. But the fortunate thing was no matter how much weight he had at the popliteal region, it was still okay. It was like the normal sized knee and popliteal area, but then the thigh was, as big as my shoulders, and the calves were really large in this man. And so it was actually okay to get it. So, I guess one of the fortunate things is, even though you have some really, large people with lots of skin tissue between nerves and your, and where your probe is, at hopefully the vital sites, your neck, there's only so much size you can get there. Popliteal is only so much size. The ankle, a lot of critical points are okay. But trying to do a posterior gluteal approach to something that's going to be difficult.
Yeah, well, one of the challenges is actually doing an anterior approach sciatic nerve block because of the depth.
Yeah, that is incredibly difficult. Yeah,
that would be really challenging. And the reason why, so with sciatic nerve blocks, look, I'll probably do a popliteal approach, just because, as you described, it is closer to the skin. You can use the gluteal approach, but that requires you to sort of flex your leg, flex the leg, and it's quite hard to sort of position the patient that way. So the anterior approach is the other one that you can sort of use, but the difficulty with that is just the depth that's required. And I must admit, I'm not proficient with using ultrasound and using the anterior approach.
Yeah, and even the image is easy enough to get, but then to put past that long needle in difficult situations with someone with a fracture or whatever it is, yeah, it is definitely advanced technique.
So, I mean, the one that I use with the most depth is, do you do many like the canal blocks?
Oh, look, I haven't recently, just because a lot of surgeons are doing LIA and it's not necessary. But yeah, that's really just below the sartorius though. So
That's right. Yeah. Oh, look, it depends on the patient, but those
definitely.
ones there, I'd use 100 to 150 millimeter needle.
Okay. Yeah.
To get those images, and those would probably be the blocks that I do, which probably require the most depth.
Yeah. Okay. Yeah. And obviously tap blocks often require.
Tap blocks. So tap blocks are quite interesting because there is a wide variety of patients in terms of body composition. So you see some, like for yourself, I probably just need to have a depth of 3 centimeters, I think.
What are you saying?
Sorry, two. Apologies.
My abs are huge. I've got to say,
there's no fat there. So whereas for me, you might have to put the probe up to about 10 to actually get to get the correct layers.
You wear obesity well, Stan.
Low frequency ultrasound, high depth for me, La. Whereas you'll be using high frequency, low depth.
Give me the hockey stick. Interesting, because I've started doing. Not started, but this was when I started learning tap blocks. At the same time, I learned the rectus sheath blocks, and they're just so much better at covering the top all the way down to below the umbilicus. I've started just to, for most, not the supraumbilical, infraumbilical gynae operations, but most laparotomies, rectus sheath block it's an easier technique. That's shorter space to the rectus sheath.
Yes,
I think it's great.
And look, I think for me, it's been a long time since I've done a tap block, because from my and I don't know about yourself, but a lot of the surgeons are just doing it on direct view. And
this was a while since I read this study, but there was no increased benefit of just any tap block versus just local infiltration.
Yes.
If I'm putting a catheter, absolutely, I think it's a great idea.
Yes.
And I've got to say, even the surgical, it's not really direct vision, because they're
you're true.
Well,
I wonder whether they're actually putting in the right layers.
Yeah, and when you say, "Are you sure you're in?" They go, "Yeah, it's expanding." But when you put a needle into tissue, it expands whether you're in a plane or not. So I don't know what this voodoo that they're
sort of whether are they sure they're between internal and transverse abdominis. So yeah, not sure.
And I got to say, if I was a surgeon, I would also say that, because you don't want your anaesthetist wasting half an hour trying to put a tap block in. I'd say, yeah, I'll do it. And then do some token thing. I'm being cynical there, but with the edge of truth.
Look, the one time that I found it useful was many years ago when I was in Darwin, so 2014, and we had a patient who had a laparotomy, and they were, for whatever reason, it was unwise to use opioids in her, and so we had the initial laparotomy, and then we had the surgeon put tap blocks in, and then we just sort of used non-opioid pharmacological techniques. And then after that, I saw her the next day, and she was really sore. And then because we didn't want to use opioid because she had an ileus, so the surgeon didn't want her to sort of make that worse. So he suggested that maybe could we put some tap blocks in. So what I did was I actually put some catheter tap blocks in, and then I would see her twice a day, and I would bolus those tap blocks, and it really worked really well. So
I literally did the same thing. I had a patient who had a respiratory arrest met call, was on ketamine and opioids, but that wasn't working. So I just went up to the ward, put a couple of rectus sheath catheters in, and just the satisfaction of doing this technique for someone who had failed everything else and was met calling because of sedation is extremely satisfying. And it's such it's not the easiest technique, but once you've learned it, it's an easy technique. Just keep the patient monitored, put the catheters in, and pain-free, 10 out of 10 to 0 out of 10 in a matter of seconds.
Big difference. Yeah, I agree. And you certainly see, they certainly appreciate and see that difference very rapidly.
Okay.
Now, I'm going to talk about the Doppler effect. So
absolutely.
Well, look, probably don't need to know sort of too much in detail, other than have a sort of good definition of what the Doppler effect is, which is It just describes the change in frequency of sound waves due to the relative motion between a wave source and detector. That's probably the easiest definition that I would use, and easiest one that I think is easy enough to remember.
And the old analogy with the ambulance or the sirens coming towards you, then moving away.
Yes.
That is everyone knows that Doppler effect.
That's right. And so it's a relative motion between the wave source and the detector. And it could also work the other way as well. In other words, it's also you could also be moving closer to the ambulance. And that's why you hear the different frequencies.
So the ambulance can be stationary with the sirens on, and you're in a car driving past. The same effect will happen.
Same effect, correct? Because it's the relative motion between the wave source and detector. So it can happen both ways. But often we talk about the wave.
What happens if you're traveling at the speed of light?
Well, you know what? Then you hit back a couple of days' time, and it never happened.
It never happened.
That's time travel, yeah.
I think you're talking about wormholes rather than special theory of relativity. Anyway, I
was watching Avengers: Infinity War the other day. So the idea of quantum physics and time travel. How interesting. Eh? But anyway, I digress. I look forward to what I need to learn. That you're going to send me to learn, but it better not be quantum physics.
Yeah, that's right. Should we go into what the equations are?
Okay, so
I'll put these in the story notes as well.
Yeah, so look, the equation in its basic description, it's the velocity. So when you think about Doppler and its use in medicine, we're thinking about looking at blood flow. So that's what we often look at. We look at we want to discern whether it's an artery or a vein. And this is for us in anesthesia. In cardiology, I think your application will be a lot different in terms of you can actually look at the velocity through the left ventricular outflow tract, and you can get things like peak systolic velocity. You can look at things like you can calculate the flow, which then can calculate the volume integrated when you integrate that over time. Now, the equation at its base is the velocity of blood flow equals the velocity of sound in blood multiplied by the shift in frequency or the Doppler frequency divided by 2 multiplied by the frequency of the beam multiplied by cos theta. And cos theta is the incident angle of the ultrasound beam to blood flow. So if you think about this, if your beam is coming straight down and your blood flow is going this way, it's the angle between the angle of the beam and the direction of the blood flow. All right.
And so you'd use this, if you're having a short answer question about ultrasound, this is what you do. This is the equation you'd use to describe the Doppler effect. Is that right?
That's right. Yeah, that's right. So you'd have your definition of the Doppler effect, which describes the change in frequency of sound waves due to the relative motion between a wave source and detector. If you can remember, which I think, yeah. Look, I don't think it's essential, but I think it's nice if you can reproduce it. You'd have the equation of the Doppler equation, which is velocity of blood flow equals the velocity of sound multiplied by the shift in frequency divided by 2 times the frequency of the beam multiplied by cos theta, where theta is the incident angle of the ultrasound beam to blood flow. And the reason why that's also important is that you want to have that less than 18 degrees, okay? Because you do get errors once it's more than that.
Oh, that's good. Now, this next question is one of the initially trickiest things. What do the colors represent with Doppler and ultrasound? Because you got to make sure that you're not confusing.
That's right. Yeah.
The ultrasound isn't fancy. Actually, blue doesn't mean
you are the king. You are the king of mnemonics. I'm sure you know this mnemonic.
Oh, look,
tell the audience.
I mean, it's BART. Blue away, red towards. BART. Blue away, red towards. And just remember, the ultrasound isn't fancy enough to show every artery as red and every vein is blue. It's not about whether it's not blue and red is not arteries and veins. That's right. It is where the blood is flowing. So more accurate is your arteries are going to be pulsatile and any color, and your venous blood flow is much slower. You may get varying colors, but not necessarily pulsatile.
That's right. So I mean, a trick is if you want to know whether it's artery or vein, move the probe towards where the heart is. So if you move the probe, so if you angle the probe to where the heart is, blue is always going to be venous because it's moving away from the heart, and red is always going to be arterial. Yeah. Okay. Because it's coming towards you.
That's right. And also just to remember that there's always a whole spectrum of things that makes you decide this. You know the anatomy, roughly speaking. So you know that that's a carotid, not an internal jugular vein. It's compressible. Veins are compressible, whereas artery less so. The artery is pulsatile, but even some veins can be pulsatile. So you have all these other factors that really helps you to decide this as well. Good.
Great.
I
so
think
that's it for ultrasound.
Excellent. Well, thank you very much, Stan. That was a good comprehensive talk about ultrasound and some really interesting information about the practical aspects of it as well. I mean, the most important thing, ultrasounds are so readily available in every hospital department. I think when I was starting training, we just got the grants to have some average ultrasounds in our departments, but it was a game changer. Suddenly, IV cannulation, outline insertion, regional blocks, cardiac ultrasound. If you're not learning ultrasound now, and lung ultrasound as well, if you're not learning ultrasound, I think you're doing a great disservice to yourself. Just learn it, because even as a junior, by learning ultrasound, you could be one of the most proficient people in the department at ultrasound. And I think that's a really great skill to have, if you're a junior.
Yeah. Look, I now routinely put all my outlines with ultrasound.
Yeah, so saves time.
Honestly, yeah, you're absolutely right. Like previous to ultrasound, it used to be, I mean, you used to palpate it, and it used to be a guessing game. And look, my success rates were probably around 60, 70%, but with ultrasound, you're heading towards 90 to 100%.
Absolutely. And you learn so much as well. I mean, I definitely think learn both ways, like usual, but you learn so much about what you were doing wrong with the non-ultrasound technique. You learn that there's, the artery moves a lot. You learn that some arteries are super calcified, have multiple false lumens, have thromboses in them. And some are just extremely tiny. So you're far more forgiving of the fact that you missed a few times, but well, that artery is ridiculously small. Of course I missed. So I think you learn a lot by doing lots of ultrasounding of both, veins and arteries.
Absolutely. So get your hands dirty. Obviously clean them, but
it's the wrong phrase, isn't it? Get your hands dirty with Chlorhex.
But with the adequate wash beforehand, surgical scrub beforehand.
That's right.
And get involved with ultrasound and have someone in the department show it to you, and just use it in everyday practice. And even now, like I think, what do you use ultrasound for IV cannulation?
Oh, if I need to, yeah. I mean, often IV cannulations, no, but I've had a spate of really difficult patients where I was very glad to have the ultrasound there, because they had nothing to go for. One arm was lymph node dissection, the other arm had no veins, the feet were swollen.
And the way you position your probe is a lot different than how you would do a nerve block. Like you would position the probe transverse as opposed to longitudinal. Is that right? Yeah,
as in I've got the vein on short axis, not long axis.
Yeah.
And then I go out of plane, whereas nerve blocks I go in plane.
Yes. Yeah.
Which I think is common.
And those are different schools. When you go out of plane on the short axis, you don't see the whole needle. All you see is just like this little shining little bright light on the screen.
Yeah, that's right.
But it's very it's very sort of satisfying when you see this black hole with like a little target in the middle. When you're in straight away.
That's right. It really is, and it's one of those I love things that are technically a bit tricky, because you really get a sense of satisfaction by being able to do those things. There's a lot of medicine is very academic. I mean, surgery, anesthetics, even, we get to really do some interesting technical stuff.
All right, good stuff, La. Great. So we'll see you in a week, and hopefully in that week, La will have a change of clothes.
Thanks for that. Okay, everyone, that's great.
And hopefully by then I'll get my beeper. All right.
Right. So everyone, we've got the Patreon account. Please support if you are able to. If you have any questions, comments, any feedback at all, lahiruandstan@gmail.com is our email account. And again, please share. Please share with anyone who might be interested in our first part podcast, Anaesthesia Coffee Break. See you next time.